Happy Friday. Welcome to this wonderful edition of Chalk Talk. I'm Tim Earhart, chaplain at Aurora St. Luke's South Shore. And today we have with us someone who is certainly no stranger to many, if not most of us, who is almost as good as bacon, Peg McGonigal. Peg's a former hospice chaplain and cardiac staff chaplain at St. Luke's. She's been a longtime proponent of palliative care. Peg served on the Palliative Care Steering Committee when the program was in its infancy at Aurora. Peg carried that support for palliative care with her into her role as cardiac staff chaplain, and she earned national recognition for her research project, Improving End-of-Life Care for Ventricular Assist Device Patients, Paradox or Protocol, through the Transdisciplinary Palliative Care Education Program, the ACE project, sponsored by the National Cancer Institute in the City of Hope. Peg has been involved in clinical ethics since her chaplain residency days, serving on the St. Luke's Ethics Committee since 1996. She was later appointed as the first non-physician co-chair in 2019. And in 2020, Peg divided her time as lead chaplain and clinical ethicist, becoming a full-time ethicist at the end of the year. And Peg currently serves seven hospitals in the continuing health service line. Like other chaplains, Peg experienced working with palliative care as teamwork amongst soulmates. The feeling continues in her role as clinical ethicist. And today's presentation, Buddies and Pals, Ethics and Palliative Care, reflects her continued commitment to collaborate with palliative care providers within the context of ethics case consultation. So glad to have you, Peg. Take it away.
Thanks, Tim. Good morning, everyone. It's good to be with you. And this is Buddies and Pals, what I know to be true. So the story begins during team rounds that morning. The nurse describes the patient's situation as a hot mess, adding, "The patient is telling me he just about done with all of this. He's been through a lot this admission of 43 days. The family is encouraging the patient to eat and participate in therapies and becoming more aggressive. They don't want to hear him talk like that. They want to keep everything positive. The patient is currently a full code. The doctors are all saying different things, which is confusing everybody. I just want to do what is best for the patient." "What is the goal?" a team member asks. "I have no idea. Depends on who you ask," the nurse replies. The team members look at each other and one states, "Sounds like a case for ethics or palliative care." The others nod in agreement. Prior to my recent role as a clinical ethicist, I was, as Tim said, I was the cardiac staff chaplain at St. Luke's Medical Center, and this was a frequent experience. Is it ethics or palliative care? You know, history and culture may indicate of that particular institution may impact if either service is consulted. Preconceived notions of what each has to offer range from a resource of last resort to a resource to fix bad behavior, ethics would take care of that, or because the patient is expected to die or is dying, palliative care. And we both offer so much more. And often the care team members aren't sure exactly what each one of us does, but they know that it would be helpful to have another set of eyes on the situation, and are often open to suggestions to consult on either service. And if they've had a good experience with either one, they are more likely to advocate or make a referral for either one. And one is needing an order, a palliative care, and the other does not, ethics. So let's take a look at the roles of each. Ethics is a clinical ethicist is an outsider, separate from the care team. We assist in clarifying values at stake. We're a neutral facilitator of communication between the care team or care team and patient and family. We are Switzerland. We assess for moral distress within the care team and provide recommendations following our fact-finding and analysis of the ethical question. Palliative care are insiders, part of the care team. They assist in clarifying goals of care. They facilitate communication between care team or care team and patient and family. Their expertise is in the trajectories of life-limiting illnesses. They have expertise in pain and symptom management, and they use a holistic approach using the 8 domains of to determine the goals of care. Dream or best practice. Consult sooner rather than later. Both of us are involved in patient care by invitation, and naturally we both tend to think consulting us earlier would be beneficial. My first experience, as Tim mentioned, working with palliative care found me convinced that chaplains and palliative care providers were soulmates. And we spoke the same language, we had similar insights and curiosities. Now, as a clinical ethicist, the feeling continues as I'm aware of how our services interact and parallel one another. I am also aware how many palliative care providers are in my personal cell phone. A true indication, I figure, of buddies and pals. That status comes to my mind. So let's take a look then at these bullet points. So this expertise in communication, this is the skill set we share. This is what makes us buddies and pals. These skills cannot be oversimplified. Communication is at the heart of what each service has to offer and is often the underlying issue for each consultation. Supporting the care team in clinical situations include the clinical, which is palliative care, and the ethical. We both specialize in the complex, from families to medical conditions to ethical questions to hard decisions. Learning and understanding the patient's narrative is key, as it typically provides context for all things and should inform the care team's approach for offering support to the patient and family. This is why I ask if palliative care is involved, because I know if they are, chances are they are in process of mining the story, improving communication and defining the goals of care, engaging the patient's and family's understanding of what's all going on to define the goals of care based on the patient's wishes and values. My practice, if I have time, is to review their notes. But when I do, I actually speak with the palliative care providers to glean their insights into the situation. Sometimes we've both been consulted, and I will suggest to the requester that we slow things down to let things unfold with palliative care, and then see where we are after that. Because I know, I understand their process of mining the story to help them understand the situation and involving the patient and family. Another way to assist the care team is the clinical ethicist will identify biases or values conflict for the team member, which may be impacting their care. And the aim is to promote awareness with compassion and understanding, not only of their biases, but also how the narrative may informs their decision-making. And problems result when goals of care become muddied or uncertain. And consults to ethics or palliative care include the need for goals of clarification. Sometimes that's easier said than done, but this is what I understand is the process of palliative care and ethics. The care team often appreciates the time and effort each service invests to support the family and the patient and the care team. Providing the opportunity for all to share their perspectives shows respect and strengthens the effectiveness. So buddies, and I'm referring to the clinical ethicists, our approach. First, to reiterate that we do not require an ethics consultation does not require a doctor's order, and we are a non-medical specialist, not directly involved in patient care, and because of this, other members of the care team will not know of the ethics consult initially, and so our approach then begins with an ethical question. What is the ethical question in this medical care? That is, how is it, is medical care being delivered ethically? And the clinical ethicist's training is based on ethics facilitation model of analysis of the nature and value of uncertainty. What should we be doing? And then we engage in the process of fact-finding to provide the context for the situation and the ethical question. And this begins by recording the requester's perspective of the case. And then we ask the requester, who else would it be helpful for us to talk to? So then we engage with other team members, such as social work or case management or other physician consultants. And once reaching out to other care team members begins, other members of the care team become aware of the consult and share it with their care team members. We apply ethical frameworks that include principles, core principles of respecting autonomy, beneficence, non-maleficence, and justice. And we are looking at how decisions are being made. The patient and the surrogate decision makers' understanding of the situation. Was there evidence of informed consent? How's the relationship of the care team and the family, just to name a few. The attending physician is notified of the ethics consult and the ethical question or concern. And to be sure, some experience it as a punitive for something that they have done wrong, but that's not why we were consulted, while others are grateful to have ethics take a look at the case. We provide a safe space by inviting different perspectives of the same situation and eliciting a conversation. The goal may include conflict resolution and consensus building, but building that safe space for everyone to be able to share their concerns is what we're all about. And unlike palliative care's involvement, ethics involvement with the patient, family, and care team may be considered fleeting by comparison until the issue is resolved. And not all consultations requests lead to consult meetings. And a consultation meeting may be held to support the care team or to support the patient and family in the care team. Fact-finding determines if a consultation meeting is warranted. And then finally, after all of this, our process concludes with recommendations. And although some of the care team want ethics to tell them what to do, we offer recommendations that the attending and care team may utilize or not. Our role is advisory. Now, PALS approach, see what I did there? Palliative, PALS. I realize I'm preaching to the choir, but just bear with me. So they use the care provider model with training expertise in recognizing and treatment of medical problems that align with goals of care. And they do so by constructing a plan of care using the 8 domains of care of palliative care. And for those, I will just mention the 8 quickly. So the structure and process of care, the physical aspects of care, the psychological aspects of care, social aspects of care, and the spiritual and the cultural, and care of the imminently dying. And then finally, the ethical and legal aspects of care. The expertise in recognizing and treating medical problems that aligns with the goals of care. You know, the goals of care conversation asks, who is this patient? And then translates into concrete goals with specific interventions. This is palliative care's gift to the care team and to the patient and family. And the goal is to provide quality of life for patients using medical treatments and medications. The patient, we know, gets to say what brings them quality of life and what they are willing to endure to meet that goal. And then applying their vast knowledge of pain and symptom control to assist the patient in meeting their goal. And they are also, palliative care is also oriented to patient and family is a longitudinal relationship with shared decision-making. And I think this is this longitudinal relationship. So across the illness, or hopefully the admission, across the process of aligning goals of care with patient wishes, this is what I appreciate most about palliative care. And they are experts in communication, and they use active listening, conflict resolution, consensus building, values exploration, all towards the goal of shared decision-making. Now, if the patient or family has dismissed or refused palliative care, I will ask the care team, how is it presented, and assess if there is possibly another chance for palliative care to be reconsulted. Now, in addition to what has already been discussed, this article that appeared in a recent edition of the Journal of Palliative Medicine, brought to me by Martin, offers other specific tips. Clinical ethicists and palliative care collaborate that I wanted to include here. And I think this might be considered for those who palliative care providers and clinical ethicists that haven't developed maybe yet into buddies and pals. So, but it's always I appreciate the article for what it brings up. So in addition to what we've already talked about, based on my experience, you know, that it highlights that ethics and palliative care promote one another. And in an ICU setting, the clinical ethicist can assist in realigning expectations and safeguard against inappropriate medical treatment. There's also successful partnerships between clinical ethicists, palliative care, and surgical services can improve decision-making around high-risk interventions. Again, mining the story leads to the solution to consider. And we can improve informed consent regarding advanced technologies for children with chronic critical illnesses. And when families request prognostic non-disclosure, so they don't want to tell mom that she's dying or has a terminal disease, clinical ethicists can help balance the patient's preferences, best interests, and possible harms of non-disclosure, working with palliative care. And clinical ethicist serves as a resource for palliative care teams responding to requests for physicians aid in dying. Clinical ethicists can help prevent, address, and mitigate moral distress. And the authors also say that point out that clinicians who practice both palliative care and clinical ethicists, because we know that there are providers that are trained to do both, need to define which role is being used in a particular situation. So I recommend that you take a peek at that article. And so my conclusion is that clinical ethicists and palliative care providers are natural collaborators. And, although I elected to have a catchy title, my efforts are sincere. We are natural collaborators. We're investing in learning the patient's narrative, including the patient's goals and values, which lead to understanding about how decisions are made. We are experts in supporting care teams in complex situations. And each has their own specific approach and responsibilities, but there are common themes. And consulting with one another, promoting one another is good for both. And then here are my resources. And the Weaver article, like I said, just came out in the Journal of Palliative Medicine. And that's what I have.
Thank you so much, Peg. Appreciate that. And I really, and I've always appreciated your focus on listening, and as you use the phrase, mining the story and getting that narrative so that things can be constructed well. So appreciate that. Doc Martin, you had something in the chat. How about a commentary from you on this?
Thanks, Peg. I appreciate it. I wanted to share a few things. I'm sorry, this is a little long-winded. So this summer, I just recently graduated. 2 years, I did my graduate certificate in clinical bioethics. And each and every semester, what I noted was how much I didn't know that I didn't know. And I felt like I had much more ignorance about ethics than I had ever realized. And so I don't know about all of you, but my own personal experience is that most of my ethics training came from attendings in real time, right, on the wards. And at least in my experience, what that meant was that it was somewhat biased. It was physician-centric. It sometimes felt like there was a right and wrong answer to some of these things. And that is not ethics, right? Ethics, by definition, is philosophy. And so any ethical question worth its weight in salt has no black and white obvious answer. And so we see this in palliative care, right? We see physicians literally pulling their hair out, getting frustrated with patients and families, struggling to understand them. Physicians going into meetings already believing that they are right, like kind of going into battle to try to convince. And I worry that some of that comes from the way that we learn this, about not maybe appreciating that there are equally valid other perspectives that have just as much weight, but that we're not knowing as much about. And that's what I felt like I learned most over the last 2 years, was the other side of the coin. And one more quick commentary. One of my favorite papers during my studies was the 5 Society paper. It's from 2015, and it brought together a number of different organizations and ethicists to come up with some plans about this term futility. And what they proposed is not to use the word futility, but to use the word potentially inappropriate. And the rationale for that was for all the things I just listed. But futile, if I start using the word futile, it implies that I've already made up my mind. And if physicians instead use the word potentially, then they are hopefully more likely to go in and listen and feel like their minds are not made up and provide a space for conversation. Those are my thoughts I wanted to share.
Thanks for that, Martin, because, my experience with being in family conferences with palliative care has always been, I would say, generous, in that I've experienced the palliative care providers to be generous with their time and patience, and wanting to hear and unfold, to unfold the narrative, the story, so that it can be applied to, to really understand, one, what the patient and family understands about what's happening. And, I think, and to assess their gut reaction, or, to be open to having that conversation. And it's the conversation piece where you're not talking at them, you're talking with them. And that's what I value about our collaboration.
Jerry says in the chat, Peg, I appreciate you pointing out that folks who do both palliative care and ethics, as I and others in the meeting do, should define in which role they're serving in a particular situation.
For sure.
Yep.
Peg, do you think that palliative care tends to be part of the ethics team just by virtue of our ability to listen and think? I mean, my fear again is there's more to ethics than that. Again, highlighting that there's still a lot that I felt like I did not know, that I did not even know, and appreciating the other side. And maybe we get there because we're listening. But I worry about palliative care providers being the sole source of ethical resolution if they don't have a formal ethics background.
Yeah. And I attended a talk, and there are some articles out there about that very thing. But I attended a talk on, is palliative care, could they be considered frontline clinical ethics? And in order to do that, there needs to be some training. So, but I can totally understand, because of the nature, the conversations, and the listening, that how people and palliative care, how they can get there. But that's, so I think, that's, I think that it's important that, like you said, knowing what you don't know. And Lord knows you and I have had some rip-roaring conversations about cases and what we were thinking, and if things should unfold a little, or what the hunches were and things like that. So I think to your point, Martin, I think that if people have an interest in ethics, that they should, and our palliative care providers, they should seek some training.
Thank you, Beck.
Yeah, thanks. Kim, you have your hand up, and go ahead.
Yes, I'd just like to reiterate what Marty and Peg were saying. I do think for a palliative provider, it requires additional training if you're going to wear an ethics hat. But I also think, even as a palliative provider, because we're involved in the patient care, and maybe we can get there, I think we're less objective, and bringing in ethics with an objective eye is often beneficial when cases are very complex, or especially long-standing, and you can't get resolution. I think ethics gives us a more objective eye because they weren't involved in the care along the way.
That's a good point. Thank you.
Thank you so much, Peg. Appreciate you taking your time to be with us today.
Good to be with you.
Yeah, and helping to further this journey that we're all on together. So appreciate it.
Have a good day.